Thank you all for coming. I'm Richard Bryant. I do work at Rotherham and do some work at the Children's Hospital as well in Sheffield. So I suppose to start, what we'll do is introduce my other colleague, Kingsley Draviraj, who also we've both been at Rotherham since about 2009 as consultants. So we started almost at the same time and work fairly closely together. So what we're going to do today is look at how to approach the painful shoulder and elbow, but really with a focus on evidence-based practice. Then we can look at what we offer at Rotherham, what to do in primary care and when to refer to us. And again, we'll include the clinical assessment and injection techniques as part of that, but if you want to go over that at the end, that's fine. So there's been a lot of focus in shoulder and elbow on evidence-based practice, and a big towards this driving the clinical, our sort of all our pathways and our decision making. As shoulder surgeons, we're all part of BESS, or the British Elbow and Shoulder Society. And certainly in the last 5 years, there are 3 big trials that our society has done, which are national randomised multi-centre trials. So the PROFHER trial, UK Frost and CSAW. And I'll go through these and then explain why. So the CSAW trial, or Can Shoulder Arthroscopy Work, was published in The Lancet 5 years ago, and basically they took patients with what looked like impingement and randomised them to 3 groups. So a decompression, so arthroscopic decompression, a placebo arthroscopy where they had the camera put in but nothing else, and then no treatment at all. And at 1 year, surgery was slightly had a slightly better outcome, but there was no difference between a placebo and an actual decompression. So surgery possibly can work, but we don't really know why that was the case. The UK Frost trial, again in the Lancet a couple of years ago, looks at frozen shoulders. 3 groups, a manipulation, a capsular release and physiotherapy, and again all improved at a year, but no difference between the treatments. The PROFHER trial, which has probably caused most of the problems we've seen as shoulder surgeons, again randomised shoulder fractures between surgery and non-surgery, and the outcome is the same at 2 and 5 years whether you operate or not, is the headline. So this changed many surgeons' approach to shoulder fractures almost overnight. They just stopped offering surgery. So this is bad news for surgeons. We've got 3 big randomised trials that have shown that surgery doesn't work either at all or any better than physio or a placebo. So we've shot ourselves in the foot a bit. But the studies aren't perfect. There's a lot of crossover, a lot of exclusions. So we kind of have looked at the results, but this has really made us think more about offering surgery. So in the past, you know, you came with an impingement in your shoulder, you were offered a decompression. We know that's not the thing to do now. So it's not saying shoulder surgery doesn't work, but I think we need to really share the decision making and have a protocol about who we offer to and when, more importantly. So certainly for subacromial impingement, this has been a big driver to try to standardise everyone's pathways. So the best website that we look at has got lots of things. There are information videos on exercises, there are information books, there's all the commissioning guidelines with a step-to-step approach on what to do in primary care. So how does this help us look at painful shoulder and elbows? Well, hopefully it gives us a structured way to examine the shoulder and also have a flow chart of how we're going to manage it, and hopefully it avoids over-investigation. So why is the shoulder such a problem for most people, including ourselves? Well, it's a complex joint. There are 3 bones, 4 separate joints. It has the biggest range of movement of any joint in the body, and it has almost no constraints, so there's nothing holding the bones together. We talk about it like a ball and socket, but in reality the humeral head is 3 times the size of the glenoid, so it's more like a golf ball on a T-peg. So what keeps it in place? Well, there are all these layers. It's a bit like an onion. So the base layer, the top left, you've got the shape of the glenoid, the labrum, that kind of suction cup, the capsule around the shoulder, all the shoulder ligaments at the bottom left. There's a whole raft of ligaments that hold the bones together. In the top right, there are 4 rotator cuff muscles to keep everything stable while you move your shoulder. And on the outside are the big shoulder muscles, so the pec, deltoid and the trapezius. So the hard part sometimes is just working out which bit of all this system has gone wrong. And when you assess the shoulder, it often just seems like a huge list of weirdly named tests. Whereas empty can, full candle lag signs, belly press, scarfs. There's a full range of things. So assessment is often very difficult. We have over 130 tests we do for shoulders, and not one of them is specific to one problem. So you do a lot of tests and they will overlap for lots of different pathologies. From my point of view, when I'm assessing, what I want to know is this a problem with pain? Is it weakness, or is it stiffness that's the issue? And your examination should kind of lead you down those paths, or is it a combination of all three? Localizing the pain can be quite important around the shoulder. Certainly if people complain of pain over the scapula and the base of the neck, that's almost not shoulder pain, or almost certainly. The three key areas for me in terms of pain is it at the front of the shoulder? That's more likely to be a frozen shoulder arthritis. That's number one. Number three, the anterolateral, kind of the deltoid pain, is usually rotator cuff or impingement related. And the last area that I ask for is AC joint pain, which is almost always just on the top of the shoulder. There are other areas, but those are the big three really. For examination, again, it's look, feel, move. So I always undress the patient so I can see the back. Look for cuff wasting, winging of the scapula. Usually it's pretty obvious. So if it's that obvious, you're going to see it, but it's always worth looking for. When they're undressed, I ask them to localize pain, usually just with one finger, but normally they just draw a big circle, which isn't always that useful. But ask them, is it over the top, is it down the side, or is it at the front? Palpation around the shoulder, you see on the medical student videos, all this spider crawling stuff. Not sure it's that useful really. I tend to go for the sternoclavicular joint, AC joint, and then the front of the shoulder. If they're localized anywhere else, you can palpate there, but I'm not sure a feel over the whole shoulder is actually that useful, especially if you've got a short sort of consultation time. And then we go on to movement. Active movements first, to get the patients doing it first. If they seem to get stuck, I would ask them to use their other arm to help, or you do it passively, so you then try and lift their arm for them. And again, you're trying to see, is there loss of movement due to pain? Is it weak, or is it actually properly stiff? I think screening tests for shoulders are quite useful, because if you can get your hands around the back of your head and around your back, you know the rotation's fine, and actually the shoulder moves fairly easily. What I tend to do is, once I've done screening tests, is just see what the forward flexion is like, see how far they can go forward. Do the same in abduction out to the side. You've already rotated behind your back, but then external rotation with the arms by the side, in particular for arthritis and frozen shoulders, is the key. And again, if you compare side to side, you get an idea of whether there's a problem or not. There are lots of tests in shoulders, like I said. I tend to keep it simple. So if I think it's more of a cuff problem, I'll do Hawkins tests of the empty cans. So Hawkins are trying to get them to impinge, trying to cause pain by rotation. The scarf test, where you lift the shoulder across, is just trying to squash your clavicle into your acromion. So that's for AC joint pain. Biceps tendonitis tends to give you pain down the front of the arm. So there are lots of tests, but it's resisted forward elbow and shoulder flexion that causes pain just at the front of the shoulder. For instability, we do what's called an apprehension test, so getting them in a position where they feel like it's going to dislocate. But there are lots of tests. We tend to focus in on the thing we are most concerned about. Rotator cuff function as well. There are lots of ways of doing it. I tend to try and combine it all in one. So supraspinatus. So assess both sides, arms out to the side. The reason we rotate the thumbs down to the floor is really to line supraspinatus up, and also to try and weaken the deltoid a little bit. And then you compare side to side. While I'm there, I'll often do the scarf test as well. Infraspinatus I do with the arms at the side, just see how far they can externally rotate. And then you push in, so it's resisted external rotation. Subscapularis, we tend to go behind the back, do what's called a Gerber's lift-off test. So you're seeing how far they can lift off. A lot of people find that too painful to get round the back. So I find the belly press test, where they put the hands on the stomach, lift their elbows forward, and again, you're pushing back into them. And if the subscap's weak, the elbow will just flop backwards, or they may not be able to bring their elbow forward in the first place. And then lastly, for teres minor, probably the rotator cuff that's least torn, is what's called a hornblower's sign or test, where you're externally rotating in abduction. So that's the 4 cuff tests. Once you've done all your tests, it's trying to fit that into a diagnosis. I quite like the Oxford shoulder pathway. I've stuck a QR code on here. There is also a little summary of the pathways, various QR codes linking to exercises and things like this, which can be emailed out as well. The good thing about the Oxford shoulder pathway is it goes through your examination, and then a bit like a flowchart will tell you what the likely diagnosis is and what to do with it. So it's quite a good way of just working through, if you're not quite sure what's going on, of working through your examination and then taking it from there. What I thought we'd do is go through a few of the common shoulder problems, but starting with age. So the young shoulder, like Nick at the back, because he's a young man. So common problems, we tend not to think of arthritis being that common, but certainly AC joint arthritis is actually fairly common. We see it in people in their 20s and 30s, but usually related to repetitive overhead jobs. So plasterers in particular always seem to get this in their 30s, or anyone who does a lot of weightlifting. So it's fairly common. We do excise AC joints for this. A lot of the cuff problems though, or a lot of the deep pain issues are due to instability, whether it's a labral tear, Bankart tear, labral cysts. Rotator cuff tears and impingement per se are really rare in the under 40s. So I would never do decompression anyone under 40 without excluding instability. So it's usually related to poor rotator cuff function. So impingement in itself rare under 40s. I would always rehab these people first because it's usually about their muscles rather than any structural pathology, and there is no role for ultrasound in these people. For the traumatic side of things, if you dislocate your shoulder at the age of 18, there is a 90% chance you will redislocate within 2 years. But as you get older, your shoulders stiffen up, so by the time you're 40, that risk is down to about 1 in 4. So again, we'd rehab, but our considerations for surgery are really based on what the soft tissues and what the bone are like. So if you've lost bone from the glenoid or from the humerus, we would tend to be more aggressive in operating, certainly in contact athletes. So I've just put up some pictures of what we do for shoulder instability. So the screen on the left is a humeral head and a glenoid, and it's got a Bankart tear, so soft tissue detachment of the labrum and the ligaments. The way we fix that is arthroscopic, so keyhole surgery, to put anchors in the bone and just stitch all that back together. So you're repositioning it, you're tightening it up with the expectation that everything will heal and stop it dislocating. If you're a rugby player or you're a contact athlete and you dislocate your shoulder and lose bone, so the thin line is where the glenoid should be. So if you lose part of your glenoid, you've got less bone to balance your shoulder on. So we tend to rebuild that bone. And conveniently, you've got your coracoid process at the front of your shoulder. So we saw that off, spin it round and just screw it onto the glenoid. So you're rebuilding the width of the shoulder. So that would be the go-to for contact athletes or if you've got significant bone loss. The outcomes are pretty much the same with both, but it's just assessing where your problem is. Is it soft tissue or bone? And that would be decided on a CT or MRI arthrogram preoperatively. So moving on to the middle-aged shoulder, these problems are mainly about rotator cuff function. Whether it's impingement, cuff tendinopathy, calcific tendinitis, frozen shoulders and AC joints, most of these pathologies you can try and separate out based on a plain x-ray. So that's the investigation we would ideally like. Subacromial pain has been a big focus, as I said, based on these national trials showing that shoulder surgery doesn't always work. So it's all about the clinical assessment, having a plain x-ray to exclude other things, and a good 3 to 6 months of rehab. There are lots of videos and booklets on what to do for patients, and I think if pain is a big issue, stopping them rehabbing, then it's worth trying at least 1 or 2 injections in primary care. And most people will improve. What we do surgically, I think if we're going to operate, if there's any doubt about rotator cuff tears or an injury, we would get an MRI or an ultrasound. I tend to scan in clinic now, so I've got a machine in clinic that I tend to scan with. So it's a quick and easy way just to see whether they're structurally fine or whether they're not. I would try injections if they hadn't already been done and offer surgery, but really as a last resort when everything else has failed. And what we do for this would be a subacromial decompression or an AC joint excision according to pathology. And what we're basically doing is stripping out the shoulder shaving off some bone just to make more space for everything to move. Whether it's the post-op physio that makes the difference or not, I don't know. So frozen shoulders are also pretty common, and the main thing you'll see in primary care is pain is the big feature with these. They're just in agony. You know, if they wrench their shoulder or somebody knocks or stretches it, it just makes them feel sick. And the key is looking at their loss of movement, in particular external rotation. So the picture here shows on one side normal external rotation, on the other it's just locked. And if you try and push them, it just feels like it's stuck. So it's the loss of passive external rotation is the key, often with pain at the front as well. Again, the investigation for primary care would be an X-ray. It excludes other pathology. So a 50-year-old with a frozen shoulder, if you get an X-ray, you will rule out other things, such as dislocation, arthritis. We do get a few 50-year-olds, late 40-year-olds who have advanced arthritis, giving them stiffness. I saw a lady who'd had a stiff shoulder for 2 years, ultrasound normal, and actually had a dislocated shoulder. So she's waiting for surgery. So there is no indication for ultrasound or MRI in a stiff shoulder. A plain X-ray is fine. If the X-ray is normal or they're just really stiff, then I think it's reasonable to try an injection, but this has to be intra-articular. Subacromial injections aren't really in the right place, and I would always organise physiotherapy. And explain the recovery of a frozen shoulder, and that it takes most people 1 to 4 years to get somewhere near normal, and a third of people actually never return to normal function. So this is not a quick and easy fix, but if people know it's going to take a while, they can go, fine, okay, I'll accept that, and just expect it's going to take time. If they don't settle, what we do is really one operation. That's an arthroscopic capsular release. So the picture on the left is a normal shoulder. It looks nice and white, nice and smooth. So that's what cartilage and ligaments and muscle should look like in the shoulder. The picture on the right is a typical frozen shoulder. So it just looks tight, looks like it's red and on fire. So you can imagine if you stretch that and it tears, it's just really painful. We move on to the aging shoulder and the problems that organising an ultrasound can cause, because it's often hard to know what's normal aging and what's actually true pathology causing pain. So if you scan 60-year-olds with no shoulder pain at all, you will find bursal thickening and bursitis in over 3/4, AC joint arthritis in 65%, cuff tendinosis in 40%, and a partial thickness tear in just over 20%. So these are patients with a normal shoulder and no shoulder pain. So it convinces, if you get a scan showing this, it convinces that they have a problem that needs an operation. Ultrasound will also miss tumour. Both myself and Kingsley have had quite a few patients over the year with shoulder pain, had an ultrasound that's normal, but when you get an X-ray have had bone tumours. So again, ultrasound has no role. Also, to do an ultrasound of a shoulder properly, you've got to be able to externally rotate and scan with the arm behind the back, and you generally just can't get them in that position. So rotator cuff tears, the red flags for us are highlighted on the flow chart, but these are the really traumatic ones with a lot of weakness, or those under 50. We want to see those early on. Degenerate tears are common, so this is again where it gets difficult, because we know 1/4 of 60-year-olds have an asymptomatic cuff tear, well over half, 3/4 by the time you're 80. So most of these don't need surgery. I tell people, even with an injury, that they often will settle down for 6 months, sometimes needing an injection, but always physio first, because most will get better. X-ray if they're not settling, and again, we'll talk about this later, but there is no indication for an ultrasound in primary care, even if you think they've got a cuff tear. The reason for mentioning long header biceps are the clinical shape of the arm here, the Popeye deformity. We see quite a lot of referrals. Generally, we're not bothered about the biceps. We don't fix it, don't do anything. It's usually been wearing away for a while and then it just snaps. So we ignore the biceps completely. But a lot of biceps tears are associated with a rotator cuff tear. So often patients find it confusing that I'm not interested in the biceps at all, but I do focus on the shoulder that's often not painful. So a lot of them do have a rotator cuff tear. Again, if the shoulder's a problem, you'd rehab it, you'd inject it, and refer on if they were really struggling with their cuff. But it's worth thinking about the cuff when you see a biceps tear. So in terms of rotator cuff repairs, we usually do it arthroscopic. So the picture top right shows the humeral head down here. This is the edge of the rotator cuff, and this should be attached down here, so you shouldn't be able to see any bone. So what we do after a bit of fiddling around is to put anchors in the bone and basically stitch across, so you're bringing the muscle down to the bone. The idea is that we just keep the tendon there until it heals itself. But it's a long recovery. You're in a sling for 6 weeks, during which time most people feel worse. It takes you 3 months to get back to baseline level, 6 months for muscle reactivation, and probably a year to reach your full recovery potential. So it's certainly not a quick fix. And I don't see patients in the first 6 weeks because they used to come back and just say, I wish I'd never had it done. We also know that if you scan the degenerate tears in particular, at least a third of them have retorn a year down the line. So again, surgery is not a guaranteed cure, but it does work well in some people. So we tend to operate on the young, whatever that might be, or those failing conservative treatment with weakness. Young can be anything. Certainly under 50, we tend to be pretty aggressive with offering surgery, although by next year, young will be 55, I think, for me. I repaired a guy who was 83, did a cuff repair because he still played beach volleyball 3 times a week. So it's not really about the age, it's about their level of function and what they can and can't do. Then for shoulder arthritis, usually the diagnosis is based on an x-ray, usually over 65s, mainly osteoarthritis. But as I say, we do get caught out by the occasional 50-year-old, so it's always worth x-raying these. Again, ultrasound not indicated. The treatment, I think it's probably worth trying an injection. With the delays for theatre, we're still doing quite a lot of operating here. But a lot of places aren't really doing anything at the moment. So it may be worth trying a steroid injection. Has to be intra-articular. Hyaluronic acid is being pushed again after being bounced back by NICE saying it's not funded. It's now being pushed again saying, well, actually, if it buys you a bit of time while you're waiting for surgery, it might be worth a go. Physiotherapy is worth trying because certainly for the cuff tear related, so the cuff arthropathies, where they've got a big cuff tear and a bit of arthritis, often with physio and injection, you can actually get most of the movement back. So I think it's worth a go. Because at the hospital, all we can offer it is a shoulder replacement. We don't do anything else for these. But shoulder replacements are good. Broadly speaking, there are 2 types of shoulder replacement. So on the left is a normal osteoarthritic shoulder, and we do what's called an anatomic replacement. So we replace the shoulder, but in the shape it was before, so a ball and socket shape. And those are for people who are probably under 75, but you have to have a normal rotator cuff function and good bone stock. A reverse shoulder replacement was always designed really as a salvage option, but it's being used more and more. So on the right, the humerus is articulating with the acromion, so there's no cuff there. So you get what's called rotator cuff arthropathy, so arthritis with a rotator cuff tear. A reverse is designed to not need the rotator cuff for it to work. So that's our option if you've got no cuff, if they're a bit older, or if the bone stock is particularly poor. A year down the line, functions the same, but just slightly different designs. So for shoulder injections, we'd give quite a lot. Most of the evidence would suggest that a year down the line, people are pretty much the same with or without an injection. But there is benefit at 2 months. So if pain is a limiting factor for your rehab, then it's worth trying an injection just to try to get them through that. Where do we inject? There are 3 main places really: subacromial, AC joint and glenohumeral. Who does injections into shoulders? Is everyone? Someone? Not really. Okay. I wish I didn't sometimes. So subacromial injections are probably our most common. And the idea of the subacromial injection is you end up in the bursa. So the bursa is underneath the acromion, but also comes out down the front and off to the side as well. So it's quite a big area. So we use a reasonable amount of steroid and local, so probably 7 or 8 mils in total. People inject from the back or from the side of the shoulder. It doesn't really matter. What you're trying to do is get the end of the needle somewhere near the front corner of the shoulder. So if you're going posteriorly, you're coming off the back of the acromion, aiming for the red circle. Again, you can do it from the side and aiming in for the side of the acromion. I do it differently from my colleagues. There's no right or wrong way as long as it seems to go in. and these seem to work most of the time. AC joint injections can be a bit more tricky. The AC joint, if it's worn out, is really narrow. So you're trying to get your needle into this space. So they're often a bit of fiddling around, a bit of poking, which usually can be quite sore. It's a small joint, so I'll draw up 2 mils of local and steroid, but usually you'll only get 1 mil in. And you want to just fall between the ends of the bones. So it's a direct approach to the top of the shoulder. You can draw it out, feel in, often need a bit of digging around, which can be quite sore, and then it's just trying to drop in. For glenohumeral injections, these are probably the hardest. It's quite a deep joint, and usually the reason you're injecting it is because of pain. So they can be quite sore to inject as well. Again, reasonable volume, so probably 5 or 6 mils in total. And again, there are different ways of doing it. Going from the front is a bit more sore, and you're feeling the coracoid, which is marked here, and aiming down and in. And if you can get your needle in without hitting bone, you know you're in the joint. Although if you're not in the joint, it's usually quite painful. It's a bit shallower. So the yellow line is where you'd go for injection from the front into the joint. Going from the back is a bit easier, it's a bit less painful, and you can get your green needle all the way. And the problem is often your muscle and soft tissues are so deep that you can't get to the joint. So if you're going from the back of the tip of the acromion, down a couple of centimetres, in a couple of centimetres, and aiming straight forward. But they're often a bit harder to get in. So that's a bit of a whiz through. I didn't know you were going to be here, Johnny. Otherwise, I'd have taken this out. So we've just been through the shoulder pathway. I say we, so myself, Kingsley, but it's all been done by Johnny, really. He just comes and shows us what he's done. So we've been through the shoulder pathway, updating based on all the studies and the reports, and also the logistics of surgery at the moment. So the pathway is good. It takes you through each of the diagnostic groups with the suggestions for investigations, and attached to the pathway are also notes on each of the diagnoses as well. So it's worth using a pathway, and that will tell you what to do and when to send it to us. So any questions on the shoulder before we go on to the elbow? No. Yes?
When would you, from GP perspective, request an ultrasound, but never?
No. The BOA, so the British Orthopaedic Association, our society BESS, and NHS England in their commissioning report, which we can email out to you, suggests that there is no indication for an ultrasound in primary care, which is a bit of a change. So an X-ray is what we want. Yeah, so that's on the commissioning guidelines. I think it can cause a lot of confusion in terms of things that flag up on ultrasound which aren't really relevant. So if you stick to the pathway, it'll talk you through what to do and when to refer on.
So I just want to find out, some of these guys, are they on like the top tips? They were there on the top tips or?
I don't know, but I can show you at the end, I've done a little summary. Is it?
Yeah, the last versions were. So the new one that's Johnny's system won't be on there yet, but it will be.
Yeah. So I've also done a little summary with the shoulder and elbow pathway, the commission guidelines, and various QR codes to exercises and stuff on our websites, which which I think Nick was going to email out to everyone. So it'll all be on there to have a look. So the painful elbow, 3 bones, 3 separate joints, the ulnar-humeral, radiocapitellar, and the proximal radio-ulnar joint. So to break it down a little bit, the ulnar-humeral joints are the olecranon, so the ulnar and the humerus, is really the hinge joint in the elbow. This allows you flexion and extension. There are recesses at the front and back to allow you to flex up fully, and also when you're in full extension it locks it in place so it's stable. The radiocapitellar joint is for rotation. So this is your radial head rotating on the distal humerus, but also forms part of the articulation down to your wrist. So what can cause elbow pain? Well, there are lots of things, but you can start to break it down in terms of where the pain is. So arthritis can cause pain anywhere, but it's usually at the back, occasionally at the front. Biceps pain at the front, triceps at the back, OLECRANON bursas and OLECRANON spurs can cause pain. But most of our pain is usually either medial or lateral. and it's the epicondylar pains, which we probably see more of. On the outside can be radiocapitellar arthritis, so that articulation, usually worse pain when you're rotating your hand, and on the inside it may be ulnar nerve entrapment, so cubital tunnel syndrome. Tennis elbow we see a lot of though. So this is pain over the common extensor origin. Lots of muscles which we tend to shorten down, but the muscle most affected is the ECRB, so extensor carpi radialis brevis, so the wrist extensors. They get pain on resisted wrist extension. Can affect the finger extensors as well, so we tend to test that. But the pain is localized around the epicondyle. Some of the differentials include supinator syndrome or pin syndrome, where the radial nerve gets trapped as it goes underneath supinator in the forearm, but tends to be a bit more distal. Radiocapitellar joint arthritis, again you'd see on an x-ray, but tends to be in the older age group, but that's more pain on rotation rather than gripping. So for tennis elbow tests, I tend to palpate, make sure that where they get the pain is actually over the epicondyle, stretch them out, flex the wrist down, it should pull on the elbow, resisted wrist extension, finger extension, and then find it quite useful to do the chair test. We ask them to grip over the top of the chair. All of those should cause pain, isolated to or starting off with the lateral epicondyle, but it can come down into the forearm as well. So what's the evidence-based practice for tennis elbow? Well, the suggested things are the commonest, so activity modification. There is some evidence for topical anti-inflammatories. No evidence really for all anti-inflammatories, also some people might find them useful. Physiotherapy is the key. And what we usually refer to in physiotherapy are eccentric exercises, so apologies to the physios amongst you. So these are exercises where you're loading the muscles, so loading the wrist extensors while stretching them out. So you lift up the wrist and then you're still stretching out the extensors whilst lengthening them. This takes a good 3 months. And I think we have to be positive that, you know, when we see patients who go, I haven't had any physio, I was just given a sheet of stuff to do at home. But they need to be told that is, it's their problem. They need to own it. They need to do the rehab. No specific investigations are needed for this. Improvement takes 1 or 2 years. So it's a long recovery. So I think most orthopaedic surgeons have had tennis elbow at some point. I only know of one person who's had an operation or an injection. We just would rather not go there. So it's just trying to ignore it. Eventually it does settle down, but it can take months and months. Surgery can be offered. People use GTN patches, ultrasound, shockwave, lasers, Botox, magnets. As far as I'm aware, none of them have any scientific proven benefit. We don't tend to do steroid injections now. This is a lady who just after 1 injection had a blanching of the skin. So liposclerosis, so the fat thins down, they get blanching of the skin. It's not an inflammatory pathology, so if you look at the histology of tennis elbows, there is no inflammation. So why are we using an anti-inflammatory drug? So we tend not to use steroids now. There is good evidence actually for avoiding it, because while some people feel benefit at 6 weeks, most people feel worse at 6 months. So it's great while they say, yeah, it's brilliant at the time, but when it wore off, they couldn't do anything. So most shoulder surgeons now and elbow surgeons have stopped doing steroid injections. There are some injections we do, what's called PRP or platelet-rich plasma. So we take 30 mils of the patient's own blood, centrifuge it down, which takes 15 minutes. And the PRP, the platelets, are this little triangle here. So out of 30 mils of blood, we get 2 mils of PRP. And you directly inject this into the common extensor origin, trying to stir it up a bit. I do it with them sedated or asleep because it really hurts. We think it works. It's probably 50-50 in our practice as to whether people get long-term relief from this, but it may be worth trying. Certainly, we'd rather offer this than a steroid injection, but most CCGs don't fund it now. Rotherham is quite good in that they pretty much fund anything you want to do. But we use it very rarely. So tennis elbow surgery for us is a last resort. Has a fairly predictable outcome, but the success rates from surgery probably 50 to 80%. So some people just don't get better. And what we do is we accept that we can't make the tendon heal itself, so we just chop it out. But it's a long recovery, 6 weeks to good movement, at least 3 months to getting somewhere near normal grip and function. Yeah, do you want to ask him?
Yeah, I just wonder about PRP and surgery. Have you got any information on, would you try PRP first for recalcitrant cases, or are there certain groups where you would try that and certain groups where you go straight for surgery?
We tend not to use PRP a lot. We probably do a couple a year. Well, we tend to only do a couple of tennis elbow releases a year now. There's been a big drive away from anything apart from exercises, because that seems to work in most people. There's no specific group. There are some people who just want it sorting, a bit like sort of Tim was saying with the trigger fingers. Some people just think they've tried everything and just want one operation. For people who are heavy manual workers, you think, well, actually, if I do this, you're going to need 4 months off work. They may decide that trying a PRP injection, they'll probably still need a couple of weeks off work, but that's more manageable. So it's more about what the patients want overall. Surgery is probably a better outcome than PRP. It's very much 50-50, I think, for PRP. Surgery is more predictable, but it's a long recovery. So it's a bit of both. What about OLECRANON bursitis? So we see a few of these. We see them because people are curious about the lumps. They sometimes get infected, have sinus formation. And when the swelling goes down, they can be quite sensitive and painful. Often associated with rheumatoid arthritis, trauma, and gout. So people try aspirating and injecting them. It's not something I've ever tried. I think if you aspirate them, they tend to come back, and there is a risk of you developing a sinus formation from where you've injected, certainly if you inject steroids. So it's not something I tried. We try and encourage patients to wait until it settles. So we'd never operate immediately because a lot of them will settle down. So I tend to give them a good 6 months just to see what happens, because as the swelling go down, they may find that actually doesn't cause them any problem. The ones we do operate on, well, we try and avoid it if possible. Removing olecranon bursts is not like removing a lipome where you make a nick in the skin and it pops out. It's firmly stuck on the skin. It's firmly stuck on the bone, so you have to carve it all out. You make a big cavity. In this case, this is gout. So there's almost no skin over the top, so it's really thin and delicate. So there's a reasonable chance of it all breaking down. So wound healing problems, infections, it can recollect. When you remove the bursa, you're taking out a protective layer between the bone and the skin. So some people find it's not swollen, but it's just really sensitive. So we don't operate on many, but most of the ones we do are pretty happy with surgery. If it is gout like this, although there are medical treatments to try to dissolve it, this would take years to dissolve. It generally doesn't go away. So the ones with gout are probably the biggest group we operate on. Elbow arthritis, we see quite a lot of, especially around here, with it being heavy industry. There are the two distinct groups really, the osteoarthritic and the inflammatory. And they're quite different because the rheumatoid group, the inflammatory group that's in the middle, they tend not to form extra bone, but they just lose their joint space. So they have pain throughout movement. Whereas in the osteoarthritis, the joint is usually preserved, so they don't have pain while they're using their arm. It's just when either they try to bend up or straighten out, it hurts. And stiffness is the problem. You can try injections for elbows. We don't do a huge number of injections for arthritis. I think the rheumatologists probably do more. And there are two ways of doing it. You can either try and use a soft spot, so trying to find the radial head, the epicondyle and the olecranon and going somewhere in the middle. Although in an arthritic elbow, it's quite hard to get in sometimes. Or you can go in from the back, where you're going through the triceps just above the olecranon into the olecranon fossa. In terms of inflammatory arthritis, our practice has changed mainly because the rheumatologists are being really aggressive with biologics and early treatments. So the old operations, synovectomy, radial head excisions have pretty much disappeared. We just don't do any. Elbow replacements are great for pain relief and function, especially in the elderly with rheumatoid, or in this case, this lady had a fractured elbow we couldn't fix, so I did an elbow replacement and got full function back within about 3 months. So it's a good operation, but there are limitations on lifting. So we would recommend a a repetitive lifting load of about 1 kilo, which isn't a great deal, so it's quite limiting. So it's largely for the rheumatoid patients. For elbow osteoarthritis, as I said, it's a bit different from usual arthritis in that it's the extra bone that causes the problems. It's the extra bone at the edges that gives you stiffness. The main problem with elbow arthritis is stiffness, not pain. And it's usually when they're stretching out. So with the extra bone, they just find that they impinge at the back and the front. So when we're assessing elbow arthritis, stiffness is usually the problem. So if they've got fixed flexions, if they haven't got full range of movement, we tend to try to bounce them out. And if they're painful at the back, that's called posterior impingement. A lot of them will feel tight at the front as well. And it's the opposite when they flex up, so they get what's called anterior impingement. But basically, it's a combination of capsular tightness and extra bone. So what do? We can try injections. They can help with pain, but they don't really change movement because this is a mechanical block. Surgical releases, we've got a whole range of things we can do, from an OK procedure, lateral column, full osteocapsular release, and even elbow replacements, although they're pretty rare. So what we do with all our arthritis surgeries, we start taking off bone from the back, from the olecranon fossa, go through the middle, take off the front, release the capsule, take off the coronoid. So you're basically trying to reshape the elbow to what it was before. We've tended to do this open in the past, although nowadays we're doing a lot more arthroscopically. So it's a more advanced option. We can see everything in the joint. You can do a full osteocapsular release. You can do it all with keyhole surgery. And in Rotherham, we probably do more elbow arthroscopy than any hospital in the region. In particular, Mr. Draviraj does the most, I think. Most people don't do elbow arthroscopy because you're never more than a centimetre from any of the major nerves in your elbow. So a lot of people just don't want to do it. We have just updated as again the elbow pathway to reflect all this, and then again that was thanks to Wayne Fletcher really for doing that. So in summary, my recommendations for primary care would be positive about the impact of physio. We know that physio, that the patient's belief, that the single biggest factor for physio working is the patient's belief that it's going to work. It have to be realistic about timescales. It takes a good, if you start going to the gym, it takes a good 3 months or more to gain extra strength and muscle bulk. So it takes a long time. Plain X-rays are what we want. We don't want X-rays or we don't want ultrasound or MRIs. And a lot of the commissioning guidance nationally from NHS England would suggest that all that's needed in primary care is an X-ray. If you do need help from us, we're very happy to offer advice by email. We would say we offer a full range of shoulder and elbow surgery options. We can scan in-house if we need to in clinic, but if you need us to see them, we're very happy to. So I'd recommend you use the pathways. As I say, we're going to send it out in an email attachment. If you're struggling with shoulder, the Oxford Shoulder Assessment Tool is quite good just for fine-tuning your examination, trying to work out your diagnosis. And I think that's it. Any questions? Apart from Johnny, is there anyone else who does shoulder injections or who would want to know a bit more on the techniques to do them? Not really. Should we call it quits there? So the three injections. So the elbow is a bit harder. We'll come on to that in a second. But for the AC joint, I don't think it works on this model, but it's trying to feel the top of the shoulder, trying to feel along the clavicle, feel the edge of the acromion, and then trying to find the gap in between. I do it with a sterile pack so I can press on. It's nice to have a non-touch technique, but it's really difficult for shoulders. So everything I use is sterile, and then you're trying to just go in. I haven't managed to get it in the joint yet on this model. So often you're just trying to work around. So often you will hit the bone, and then all of a sudden you'll move it a little bit, and it'll drop in. So it's just trying to work along the bone. It can be a bit sore. So I tend to use an orange needle or the finest needle you can until it drops in. Glenohumeral joints from the front. Again, you can't really see the landmarks on here there very well, but the coracoid is a peg of bone at the front. So I've got my finger on the coracoid and I aim just above and then down and in. And if you can get the needle all the way in, you know you're in the joint. Otherwise, you'd either be on the coracoid or on the humeral head. Subacromial injections, trying to feel the edge of the acromion. And then, if that's the front corner, down a little bit, back a little bit, and then aiming in. From the back, usually the back corner is quite easy to feel. So you can feel the back corner and just go underneath and aim forwards. The glenohumeral joint, with the subacromial injection, you're aiming up and out. With the glenohumeral injection, normally going the other way, you're normally aiming down and in that way. But they're usually quite hard to get in. Does anybody inject elbows, apart from Johnny? No. The elbow injections we just don't do many of nowadays anyway. I'm not sure I could. I didn't get it in this one either when I tried the other day. So we're talking about the soft spot. So you could just go feel the OLECRANON. So that's the ulna, feel the OLECRANON, feel the tip of it and go above. So you're going into the OLECRANON fossa, straight down into it. For the soft spot, it's trying to feel the OLECRANON here, lateral epicondyle, radial head, so it forms a vague triangle, and just trying to go somewhere in the middle until you're in. But again, often a bit of wiggling around till it drops in. I've got a bit of a bent needle on that one. For tennis elbow, if you were doing it, or PRP, again, it's where the pain is maximal. So usually the epicondyle, you can feel the ridge usually coming at the back, and then it's usually just in front. But you're trying to get into the muscle and down onto the bone. So it may be that what you're doing with the needle when as you're sticking it in and out is just agitating and making it bleed, and that might be the therapeutic bit rather than the steroid. Any questions on injections, or happy with examination? Anything you want to go through before we finish?